the vascular endothelial cell growth factors and other angiogenic growth factors. And then, certainly in a large excisional wound, the fibroblasts, as they move into that matrix, will recognize that matrix and begin to contract it through their integrin receptors by converting into myofibroblasts. And certainly contraction is an important component of the normal wound healing. And then finally, as you're aware, after say maybe 3 months out to a year, that an enormous amount of collagen that's made during the early wound healing phases will actually be partially removed, and a remodeling of that matrix will occur, allowing the initial red raised scar to remodel back to normal architecture. So, looking at it, just summarizing for you one more time some of the more important molecular and cellular aspects of wound healing. When we start out with an acute wound, we undergo the release of the growth factors and cytokines from the platelets. The inflammatory phase initiates but then is reduced. We have reactive oxygen species that help to prevent bacterial infections. The provisional wound matrix gets replaced with appropriate scar tissue. Epithelialization contraction occurs, and we go to a mature matrix that repairs but does not regenerate the original wound structure. So, take a breath for a second, because that was Biochemistry 101 of wound healing. So now, what happens when we have a chronic wound? So let me ask you, if I was to ask you, do you think that these different clinical etiologies are common at a molecular level? How many would say, yeah, they're probably common, or no, they're really different? How many would say you think they're the same? All right, how many of you would think they're really different? All right, good, excellent. So what I'm going to try and show you in the next few minutes is that at a molecular level, these very different clinically appearing chronic wounds are very similar at a molecular and cellular level. Now, why is that important? Because if there is a common molecular pathology of these different etiologies of chronic wounds, then it gives us an opportunity to try to design a more common logical approach to healing these wounds. Now, I'm going to show you this hypothesis, and then I'll show you a crammed data slide that tries to summarize and support this concept. And this hypothesis is that almost without exception, in a chronic wound, as it develops, remember, from an acute wound, all chronic wounds start out as an acute wound, that there are repeated injury and especially concepts of ischemia, areas of ischemia within the wound. And this sets off the inflammatory cascade just like it does in a normal acute wound. But unlike in an acute wound, chronic wounds, or acute wounds, convert into chronic wounds because at a molecular level they see repeated episodes of injury and ischemia. The reperfusion ischemia that we heard about from Professor Moffitt in terms of the chronic venous ulcer. In diabetic foot ulcer, the stepping and pressure that's applied to the plantar surface of the foot and so forth. Certainly in regular pressure ulcers, the hallmark of that is repeated bouts of prolonged ischemia. Within this prolonged inflammatory response then, the inflammatory cytokines, particularly tumor necrosis factor alpha and interleukin-1 beta, do what they normally do in an acute wound. They draw in inflammatory cells and they undergo this production and release of proteases along with their other reactive oxygen species. And unfortunately, in a chronic wound, it is the off-target effects of those proteases and reactive oxygen species that lead to destruction of essential components that are necessary for the wound to heal. Particularly, those are growth factors and their receptors, the extracellular matrix, and the components that are required for those cells to migrate properly. And it is the result of this biochemical cascade phenomenon that leads to the chronic non-healing wound. Even reducing that more simply into just a concept of balance versus imbalance. In a healing wound, what we have is a peak and then a reduction and a drop-off of inflammatory cytokines. We also have a peak and then a release and a reduction in the proteases and the reactive oxygen and the reactive nitrogen species. We have an intact functional matrix, initially starting as a provisional wound matrix, which gets converted then into the initial scar matrix. The cells that migrate into that provisional wound matrix are very competent and can respond to the high mitogenic activity of the growth factors that are released in that wound environment. This results in the injury progressing through those phases to healing. In chronic wounds, what we find at a molecular and cellular level is exactly the opposite. There's a high, prolonged level of inflammatory cytokines. This leads to high levels of proteases and reactive damaging species of oxygen and nitrogen. Degraded non-functional matrix because of these off-target effects of the proteases. They also degrade the growth factors in their receptors, which causes the cells to be unresponsive to growth factors that are made locally. And eventually the cells, after trying to repair this injury after months, weeks, months, and in some cases years, the cells actually begin to approach senescence, so they have a poor ability to respond. So now in this very compressed data slide, what I'm going to show you very quickly is just the molecular evidence that supports that hypothesis. So in collaboration with Naomi Tringove and Mike Stacy at Fremantle, looking at 15 venous ulcer patients before and then 2 weeks after compression and hospitalization as the wounds began to heal, you can see that molecular analysis of the wound fluids show that there is a consistent elevated level of inflammatory cytokines, in this case interleukin-1, and that as those wounds begin to heal 2 weeks later, these levels consistently begin to decrease down into ranges that are consistent with what we see in healing wounds. Similarly, elevated levels of proteases, particularly in this case, the matrix metalloproteinases, start out very high, almost 50 to 100 times higher than what we would see in an acute healing wound. And 2 weeks later, these almost perfectly consistently drop down to levels that are, again, approaching levels that we see in a healing wound. The growth factor activity, evidenced here by total mitotic activity on fibroblasts in cultures, start out relatively low and increase as the wounds begin to heal up to a range that is comparable to what we see in, for example, in 10% serum in cells in culture. And then finally, looking histologically from data from Sarah Herrick, what you can see in this, these two panels, immunostain for intact fibronectin, is that at the edge of a chronic venous ulcer, there is intact fibronectin in the matrix. This is the matrix, the dermis would be up here. And as you move into the ulcer base, you can see an almost total absence of intact fibronectin in the base of this chronic venous ulcer. 2 weeks after applying appropriate compression therapy, as the epithelial edge begins to migrate across the bed of the wound, you can see now in this previously devoid area of fibronectin, abundant intact fibronectin present, because the proteases have been reduced and the fibronectin is now able to remain intact and remain in the matrix. This fibronectin is extremely important because that is the predominant matrix component that epithelial cells used to recognize and migrate across. So until the fibronectin persists in an active form long enough in the wound matrix, the epithelial cells build up at the edge of the wound, and you've seen that clinically with that ridge of epithelial hyperplasia that occurs at the edge of the wound. That is because those cells can't sense what they're supposed to move across. The fibronectin is degraded. And only when that fibronectin begins to accumulate in sufficient amounts can the cells recognize it with their integrin receptors and appropriately move across the wound bed. So, if this hypothesis of chronic wounds that I showed you is true, is there a way that we can reverse this hostile molecular environment? Can it be corrected? And the answer I would hope to convince you is that yes, by applying principles of wound bed preparation. And these principles of wound bed preparation have been captured in this acronym of TIME to focus on 4 essential components of trying to address a non-healing wound. And those are the tissue components, infection, inflammation, moisture balance, and the edge. And because of time, I won't go into this in detail. 3 years ago, when this was a new concept, I dealt with it in detail. I encourage you to look at this supplement in wound bed, on wound bed preparation, wound repair and regeneration. But the key for us is that this is really an integrated, systematic approach to trying to address components that must be corrected for wounds to heal.